Afternoon, ladies and gentlemen. Before we begin, just a reminder that CUA Point and A certificate will be delivered to you by email after you fill out the Google form. And all the questions for today's meeting can be written down in message box on your screen below. And for all the questions will be discussed in the end of the session. Okay, we start from the meeting. Good afternoon, ladies and gentlemen. I hope you are all in good condition. Welcome to the MCUE online. This is our second online meeting due to the pandemic situation. We hope that the pandemic will be over soon, and we look forward to hold another MCUE live meeting and hope to see all of you again. Today, we will be discussing about oncology, urology with many interesting topics. And today we have a special guest speaker from Japan. First, I would like to welcome to our international speaker from Japan, Prof. Shigeo Hori and Professor Suji Isotani. From Indonesia, we have Dr. Lukman Hakim from Airlangga University, Surabaya, and Dr. Agus Rizal from Indonesia University, Jakarta. And last but not least, we have our own speaker, that is Dr. Taufik Nurbudaya from Brawijaya University, Malang. Without further ado, we would like to invite Professor Hori to deliver the first lecture about genetic-based treatment for urogenital malignancy. Prof. Hori, the time is yours.
Well, hello everybody, and greetings from Tokyo, Japan. And I truly wish this COVID-19 pandemic will be subsided in both Indonesia, Japan, and also all over the world. And also, thank you so much for inviting me to this wonderful meeting. And also, I congratulate on Dr. Sepuluta, Dr. Budaya for establishing this very impressive online meeting. So let me upload my slides. Can you see my slides? Can you see my slides? Okay.
Yes.
Okay. Yes. Thank you very much. So this afternoon, I will talk about genetic-based treatment for the urogenital malignancies. And let me, okay. So this is my COI. And let me just, okay. So what is genome medicine? So genome is originally a set of minimum chromosomes necessary to live, but currently the term genome broadly refers to the entire genetic information contained in DNA. And the genome medicine actually refers to medical treatment effectively and efficiently based on genomic information. So genome medicine includes diagnosis, prognosis, monitoring, and drug selection. Okay. So I'm going to talk about for the next 15 minutes about the genomic prostate cancer, mainly genomic medicine for prostate cancer. And for the biomarkers of prostate cancer diagnosis and treatment, there are several topics. The first is disease susceptibility and the disease risks, which will be shown in SNPs, PCA3, and other tests, and also risk stratification. When you are diagnosed with prostate cancer, what will be your adequate treatment? So you can have a genome risk stratification, and there are several services available in the world now. And also, finally, what prediction of treatment response for the prostate cancer? And I'm going to talk a little bit on the research of circulating tumor cell, and especially for androgen receptor variant status. So I think you all familiar with single nucleotide polymorphism, SNP. So in our gene, we have a diversity for nucleotide, which may not change your amino acid in the protein, but the subtle changes of amino acid can actually change the activity of the enzymes. So this is called SNPs. And there are a variety of SNPs all of our genome. And let me introduce this study, which is published 2 years ago in Nature Genetics. This is a very gigantic data about what's different from patient with prostate cancer and normal control. Is there any changes for their SNPs? Actually, they identified 62 SNPs, which is associated with the occurrence of prostate cancer. And actually, that the one locus is significantly associated with early onset prostate cancer, which is 50 years old, younger than 50 years old. So if you have those SNPs as a data, and you can count how many SNPs you have for the risk of prostate cancer. Of course, individual SNPs has very relatively small contribution for the development of prostate cancer. But for example, among 62 SNPs, you have, when you have 10 SNPs, maybe your risk will be a little bit elevated. If you have more than 20, your risk will go up. So, and when you have a patient whose PS is elevated, you will consider prostate biopsy. Of course, patient PSA value is like 100. You have no doubt to do prostate biopsy. But if your PSA value is just like 4 point something or 5, the question is whether you can find a clinically significant cancer. Of course, PSA screening is not capable to diagnose clinically significant cancer. So is there any way to selecting clinically significant cancer? One way is to use a multi-parametric MRI. And if the MRI shown a region suspicious for prostate cancer, you may go ahead and do a prostate biopsy. There are any other tests like a PCA3, which is to measure, to assessment using a urine test, or PHI, prostate health index, which is PSA derivatives, and this is an algorithm to calculate the risk for prostate cancer. And there are other scores, and of course, SNPs. And also, for the treatment of early stage prostate cancer, you have many treatment like surgery or radiation therapy or active surveillance. And so what would be the good treatment by the genomic information? There are genomic tests, several genomic tests, mainly based on the gene expression inside the prostate cancer. So the commercial name is Oncotype DX or Prolaris and Decipher. So this is Oncotype assay, which is basically to measure the expression of genes associated with a worse outcome for prostate cancer, such as BGN, collagen 1A1, such that, or genes associated with better outcome for androgen signaling and cellular organization. So it's a combination of multiple pathways. And to measure those gene expression inside cancer, you can get the predictive data, predictive idea for the aggressiveness of your prostate cancer. And this is another test, Decipher test, which is basically the same idea to measure many RNA biomarkers, gene expression, many genes, which shows the aggressiveness of the prostate cancer. And by doing this test, Decipher test will detect candidates for early adjuvant treatment in high-risk group. So if those biomarkers are positive, single therapy such as surgery or ADT or radiation may not be enough. You need to combine as adjuvant treatment for those high-risk patients. And this is actually the Decipher test detail. So for clinical data, you can have NCCN risk stratification.
Sorry, Juliet, you're mute.
Can you hear me?
Yes, I can, Prof.
Okay. So, so for this is NCCN risk group, and you can combine with genomic classifier group. So upper panel shows this is NCCN risk factor and the incidence of metastasis. But the trouble is you cannot really discriminate low risk and high risk. But combined with the genomic data, you can have more stratified data for the chances of metastasis. For the metastatic cancer, situation is more complicated. And this is a paper published 2 years ago in Cell journal. And so they measured whole genome sequence and also whole transcriptome, which is a messenger RNA sequence of the prostate cancer. So it provides a very comprehensive view of structural variations of the genome. And so they measure more than 100 prostate cancer metastases. And actually that the androgen receptor and the MCUE is a quite important factor for the metastasis. And also inactivation of CKD12 or TP53, which is very famous tumor suppressor gene, and the BRCA2, which is, I will discuss later, affect distinct classes of structural variation of the genome. And actually, androgen receptor is affected by mutation or structural variation in a majority of metastatic castration-resistant prostate cancer. So this is the in the situation of a metastatic prostate cancer, the trouble is tumor heterogeneity. So in the metastatic site, it's not the same for genetic constituent. So each part of a metastasis may have a different set of mutations. So if you biopsy one of those portions, may not be enough to know what would be mutated in those metastases. So this is called tumor heterogeneities. And of course, if you have random biopsies, many biopsies, you can get more information about what's wrong with genome, but it will give the patient more burden and also technically difficult. So the idea is if you can measure circulating tumor cells, which is cancer cells circulating in the blood, or maybe some cell-free DNA, which is floating in the blood, or exosome, which is excreted from the cancer cells. Those, if you get genomic information from those so-called liquid biopsy, it will be useful. It can provide you a useful strategy against tumor heterogeneity. So idea is a tumor cell which is migrating inside the blood is more powerful, more power for metastases. And to know the genome information is important to decide a treatment. So for the metastatic castration-resistant prostate cancer, you have many pathways for the treatment. You can start either chemotherapy like a docetaxel, or you can start androgen target therapy like abiraterone or enzalutamide. There are so many pathways, so it's very hard to decide. So I'm going to introduce you the idea of circulating tumor cells, CTC. And the CTC is present in the peripheral blood of patients with most type of advanced cancer. But actually, the number of CTC is very small, but it can be detectable from 10 to 8 or 10 to 9 of blood cells. And however, having said that, there's uncertainty around the sensitivity of CTCs in low volume cancer in comparison with cell-free DNA or microRNA. So the idea is in a metastatic situation, CTC can be easily monitored, and also you can get a good idea. But in the early stage cancer, most of the case, CTC is not detected inside your blood. So I'm going to discuss about androgen receptor splice variant. And ARV7 is very famous androgen receptor splicing variant. And androgen receptor have a ligand binding domain. So testosterone or DHT actually binds here to cause the gene expression of androgen receptor. ARV7 actually lacks this ligand binding domain, and this is constitutively active. So without ligand, ARV7 can function as a transcription factors. And inside the circulating tumor cells, if ARV7 is positive, either enzalutamide or abiraterone is effective for the treatment of metastatic CRPC. So this graph shows that the blue one is ARV negative. So enzalutamide can decrease PSA value. However, ARV7 positive patient, the drug cannot be effective to decrease the PSA, or PSA just increase, which is refractory to the treatment. However, docetaxel or cabazitaxel, ARV7 status is not affected for the efficacy of taxane chemotherapy. And what we're doing in a laboratory is in the morning, we draw blood from the patient, we measure circulating tumor cell. And in this panel, you can see some patients have PSA, which shows prostate cancer tumor cells inside the blood. And also you can actually detect androgen receptor and androgen receptor B7, ARV7 from here. So usually it takes 5 hours. So in the morning, the patient draw blood, and in the afternoon, they can have data whether they have ARV7 negative or ARV7 positive. And this actually shows immunohistochemistry or circulating tumor cells. So DAPI actually stains the nucleus of the cells inside the blood. And actually this is, the pink one is white blood cell, and the CTC is shown green. So CTC usually seen like this single cell. However, in some situation, a CTC can form a cluster like a raft inside the bloodstream. Of course, you have this single CTC, but this cluster CTC can attach and also can migrate to cause metastasis more powerfully than single cells. So this is a clinical sequence of a patient who is a 70 years old lawyer, and the patient received radical surgery and also local recurrence, and he received radiation therapy. So PSA, but however, he developed metastatic CRPC, and abiraterone was administered, and the PSA declined, but there was a recurrence. So we measure ARV status in the CTC. So there's a band here. So the patient developed ARV7. So we changed medicine from abiraterone to docetaxel. And actually that a patient responded well to the treatment with docetaxel, and the PSA went down again nicely. However, there was a recurrence, and at this moment we measure ARV7, but there was no ARV7 positive cells. So we changed again to abiraterone, and there was an increase in PSA, but no further increase. So abiraterone was effective to some extent for a while. So this is a clinical application of CTC for the decision making of the treatment. And actually, there was many retrospective studies shows that AR target medicine such as enzalutamide, abiraterone, and now many medicine is now approved in the United States or other countries, but those medicine probably worked for ARV7 positive cells. If the CTC is negative, ARV7, if the CTC is negative, AR targeting medicine is very effective. And however, ARV CTC positive, and this is ARV7 negative. So this is CTC plus, but ARV7 negative status. There may be some refractory for the AR target medicine. If the ARV7 is positive, most of the patients won't respond to AR target medicine. So this panel shows overall survival in CTC negative. This is blue line CTC negative patient, and the yellow line ARV7 negative but CTC positive. And this gray one is ARV7 positive population. So apparently ARV7 positive cells are not doing well with AR target medicine. But those are retrospective studies. And in Juntendo University Hospital, we did a prospective study to use cabazitaxel and docetaxel in CTC negative population, CTC positive but ARV7 minus population, and the CTC plus ARV7 positive population. So apparently that there was no change in terms of overall survival. And I think everybody know Angelina Jolie's stories because she has familiar cancer genetic dispositions. So she decided to remove her breast and ovary because she has a BRCA2 mutation. BRCA is a DNA repair gene. And actually, about 12% of metastatic prostate cancer has DNA repair gene mutations. Most popular one is BRCA2. This is around 40%. And following is ATM or CHEK2 genes. So this DNA repair gene mutation in BRCA gene is not only for breast cancer or ovarian cancer, but also you can see in the prostate cancer. And now a new medicine was developed called olaparib, which is a PARP inhibitor, which only works for the cancer which has DNA repair gene deficiency, such as BRCA1 or BRCA2 mutations. If the patient has cancer has DNA repair gene defect, this medicine, it works very well for the metastatic prostate cancer. But if there's no DNA repair gene defect, the drug is not so effective. And also another topic is if microsatellite instability. This is another form of genomic instabilities, but if this MSI is high, for example, that for bladder cancer, immunocheckpoint inhibitors are effective. And actually in the prostate cancer too, if you have MSI high situation, PD-1, which is immunocheckpoint, so anti-PD-1 therapy like Keynote can be effective for even the prostate cancer. So this is my summary slides. And in prostate cancer, genomic medicine is being applied to clinical practice, as well as other type of cancer, from early cancer diagnosis to treatments of advanced cancer. Liquid biopsy such as circulating tumor cell analysis is minimally invasive. And also, this method is useful that can observe gene mutations over time and can be clinically applied as a useful tool for CRCP treatment selection. Now, therapeutics based on genomic information, such as PARP inhibitors for DNA repair gene deficiency, for immunocheckpoint inhibitors for MSI high, is being applied for prostate cancer treatment. So this is my presentation, and thank you so much for this wonderful opportunity. Thank you very much for your kind attention.
Thank you, Prof. Hari, for your amazing presentation. And I would like to proceed on the next speaker. Our next speaker is Professor Isotani. He will deliver about the robotic nephron sparing surgery using 3D model. For Professor Isotani, the time is yours.
All right. So, hello, can you hear me?
Yeah.
Okay, okay. So, good afternoon. My name is Shuji Istani. Thank you, Dr. Taufik, for contacting me to and support this meeting. Unfortunately, this time I could not visit your hospital because there are COVID, there are pandemics, all over the world. However, I got such opportunity to do an international lecture through their website from Tokyo, Japan, to Malaga, Indonesia. So before my talk, please allow me to introduce my university a little bit. So Juntendo University Hospital is located in the central area of the Tokyo city. We focus in the field of medical health and sports science, and we have 5 graduate undergraduate programs and 3 graduate programs. So this is the image of the Juntendo Hospital in the past. So it was...
maybe you can share screen. We can see your video, but not your screen.
You cannot see my screen?
Yeah.
Oh, okay. You're doing again.
Okay, it's
okay. So I'm going to do it again.
Yeah. Okay.
Sorry.
No problem.
Yeah. So can you see my slides?
See it clearly.
Okay. Can you hear my voice?
Yeah, yeah.
Okay, this is a Juntendo University Hospital now. And also this is past. It was 1838. So Juntendo University started at the first private medical school in Japan. And now we have over the 1,000 bed and 1 million outpatient clinic per year. So these two buildings is our main buildings. Actually, the Dr. Tawik, he visited us for 3 months in 2018. As you know, the Dr. Tawik work and study very hard with a strong passion. For example, in Juntendo, he got learned how to handle the surgical robot Da Vinci using a renal model for a partial nephrectomy. So, and after the robotic training, we went to the local restaurant, having a really good time there. So if you guys are interested in visiting us, Juntendo, in Tokyo, so please contact us or ask Dr. Tawfik so how to get a grant to visit us. I am very happy and very welcome to you see guys in our hospital. So there is no conflict interest in my presentation. So my topic is about surgical imaging. This is a movie of our university in our daily clinical practice for the robotic surgery. We use a surgical planning for the robotic partial nephrectomy and doing a robotic surgery with imaging assistant at the operation room. I believe these image assistants such as surgical planning and surgical navigation allow us to perform the next generation surgery. So I'm not sure in Indonesia, but recently in all over the Japan, the numbers of the patient who has T1 small renal tumor is increasing. For example, this is our typical case of partial nephrectomy. A healthy 6-year-old man was referred with a 3-centimeter renal tumor of one side of the kidney found by the ultrasound examination of medical health checkup. There's no symptoms. So perhaps 10 years later, so you may notice that you may be in the same situation in Indonesia. The reason why the patient who have such as early detection of the renal cell carcinoma without any symptom is this. This is a CT scanning. The development of imaging studies such as CT or ultrasound gave us a powerful early diagnosis of renal tumor. There's one paper published out in USA at 2008 that showing the early stage T1 RCC is increasing and the late stage T4 was decreased. Now the majority of the patients found in RCC is early stage T1 in USA, and actually the same trend was observed many countries. Japan, Korea, Singapore, China, and United Kingdom, the French, Germany, etc. So mean that we have the patient trend, early stage small mass is increasing very rapidly. So in such patient, I mean the patient has a small renal tumor, that we need to offer safe and effective surgery with functional rehabilitation. For this purpose, I think that it's better to consider introducing the robotic partial nephrectomy rather than the open surgery. In Japan, we started robotic partial nephrectomy at 2010. First 5 years, it was not covered by the health insurance. We have done the clinical trial to show the benefit of the robotic partial nephrectomy. At 2016, robotic partial nephrectomy was covered by the health insurance. So after that, robotic partial nephrectomy was rapidly increasing. Now over the 3,800 cases were performed at last year in Japan. So what is the benefit of robotic? So looking at the literature, the robotic partial nephrectomy is associated with more favorable result than laparal and open surgery. In conversion rate to open or radical surgery and warm ischemic time, change of renal function, and shorter hospital stay were the benefit. These analyses clearly show that the robot has many important clinical benefits for the patient. And also with my personal impression, the most drastic benefit is using robot is expanding the indication of partial nephrectomy to more complex cases. For example, these cases are difficult complex cases. For example, there are large tumor, T1, 2, T2, and endophytic, and also the higher tumor, cystic, and sometimes multiple, and sometimes they are solitary and high stage CKD. These are very complex cases. We used to do not do the laparal partial nephrectomies for these cases. We are doing the radical or open partial. However, now we start to consider these complex tumors as a candidate of robotic partial nephrectomy. This means expanding indication to the complex cases. For these complex cases, we use an image assistant at the surgery. It's a very useful tool for especially the difficult surgery. We mainly use the imaging assistant in a two ways. So one is surgical planning, and other is surgical navigation. This imaging assistant is carried out by the computer. I use a Sony Bio laptop computer, Windows 10. Of course, another computer you can use, Samsung, Asus, LG, Acer, etc. is okay. So in the Nintendo, we have done many imaging studies for these 10 years. We have been working together with Fujifilm company to make imaging software, which is able to make surgical planning, robotic partial nephrectomy. This software was released in the market 5 years ago. Using this imaging software, we can extract the intrarenal structure with semi-automatic manner. As shown here, we extract the renal arteries, renal vein, urinary tract, and two more, the renal parenchyma from CT scanning data. We call this step as segmentation. Now, after the segmentation, we are doing the surgical planning. In this step, we determine the size of the excision margin of the tumor, and we are able to cut the virtual kidney with any margins setting and the cutting angle. We can see through the opaque resection margin to observe the cut surface. So if the correcting system appear on the cut surface, it probably means opening of the correcting system. We also able to see the arterial involvement on the cut surface. The renal arteries shown in red. So these are very important information to plan the margin size, avoiding the surgical complication and the positive margin. With this software, we can simulate the port placement also. The green bar in the left window is a virtual scope, and the right window in the scope is a scopic view of the virtual scope. So as you can see here, we can simulate the port placement with this software. That's gonna help us to the planning of the port placement. And also we can do the simulation of the vascular supply territories by the computational calculation. So blood supply area was shown in the different color coded areas in the 3D manners. So it is used for determining the point for a selective clamping. So with this method, we are able to identify the arterial supply to the tumor. In this case, virtual ischemia is carried out the 2 points of each two black arrows. So we perform the selective clamping in a real operation with this 2 target point of the renal artery and get a good vascular control for this case. So at the operation, we use the imaging analysis at the surgical navigation. We put these computer image into the surgeon console Tile Pro to see the at the surgeon console during the operation. So the questions I get most frequently is how accurate we can reproduce a surgery at the planning. This is a comparison of between the preoperative surgical planning and the result of the real operation. It's not working, but okay. So as shown here, the renal structures shown in the surgical planning appeared almost perfectly in a real operation. So it means that the tumor excision was performed in the exactly same manner with virtual planning. So from here, so I'm going to show the 2 typical cases to tell the benefit of the imaging assistance.
Excuse me, Prof.
Yep.
Isotani.
Yes.
The sound is very quiet.
Yes.
We can hear the explanation of the
You cannot hear.
presentation. No.
Because the tumor was completely endophytic, it is difficult to
Yeah.
know the location and extent of the tumor.
You can hear it?
Blood flow distribution is also
Yeah,
difficult
we can.
to imaging. The standard treatment is to perform a partial resection with total clamping. However, in this case, using virtual simulation, we were able to identify the artery supplying the tumor and target area preoperatively. This allowed us to plan robotic partial nephrectomy with selective clamping. This is preoperative virtual reality partial nephrectomy. Purple is the tumor. The incision surface at the time of tumor resection as planned is shown in light green. Utilizing the software, we were able to identify which artery supplies the tumor in adjacent target area. By clamping the diameter of 2 millimeters of the renal artery third branch shown in yellow, arterial bleeding was controlled from the resection plane. By performing a selective clamp, potential ischemic area is 18.6 centimeters cubed compared to 134 centimeters cubed if a full clamp was performed. We pick up the case with kidney exposed. Where it looks white on the exposed renal surface is the tip of the tumor. We identify the tumor with renal ultrasound and identify tumor margins and mark them out on the kidney surface. We then isolated the tertiary renal artery branches. Utilizing 3D imaging, we were able to isolate the branch that, when clamped, would provide ischemia to the tumor area. We aligned our virtual navigation with intra-op findings to confirm we have clamped the correct branch. The ischemic area is identified in yellow. Cutting into the kidney, there was minimal venous bleeding, allowing us to see and excise the tumor safely with minimal normal parenchymal loss and minimal potential ischemic damage. The suture of the renal parenchyma was done on the inner layers of the 3O vicryl and was followed by the releasing of the arterial clamp and renal outer suture by 2O V-locks. There was no bleeding after the suture. Surgery time was 121 minutes. Ischemic time was 18 minutes. The amount of bleeding was 100 milliliters. Negative margins in eGFR was not significantly changed 1 month after surgery.
Okay, as my conclusions, we think the imaging simulation, the partial nephrectomy, allow us executing the anatomical partial nephrectomy with performing the without performing the real operation. They may give us the better surgical outcomes. So thank you very much. Okay, can you hear? Yep.
Yeah, I can hear. Thank you for your presentation,
Mhm.
Professor Isotani. Yes, very, very extraordinary presentation. On the next speaker, I invite Dr. Lukman Hakim, PhD. Will talk about the combination targeting therapy in advanced kidney cancer. Dr. Lukman, the time is yours.
Thank you, Dr. Penta. Oh yeah. Actually, may I share my slide, please? Okay.
Yeah,
Okay.
you can. Okay.
Dr. Penta, can you see my slide?
Yeah, we can. We can see.
Okay. So first of all, I would like to thank the organizing committee, Dr. Kurnia Penta, Dr. Taufik. It's a great honor to be invited and discuss with all of you. Also, I would like to say hello again to Professor Horie and Professor Isotani. It's been also a pleasure to meet you again in this teleconference. So I was asked by the organizing committee to talk about the combination treatment of targeting therapies in advanced prostate cancer. So there is actually an important shifting of the guideline that I'm going to emphasize in our teleconference this time. I would like to start with all of you in my first slide. And as a reminder, what the European Association of Urology guideline mentioned about the systemic treatment for advanced prostate cancer. So for your information, I'm not going to talk about localized kidney cancer, not also locally advanced, but my talk will focus on advanced kidney cancer or metastatic kidney cancer. So the EAU guideline, if you see in my first slide, this focus on the first line therapy is basically categorizing the kidney cancer, the RCC, in different stratification of risk. So the IMDC criteria, if it concludes a favorable risk disease, then the first line treatment are either sunitinib or pazopanib as first line therapy. Also, if you see the intermediate and poor risk disease, here we can see already the immunotherapy involving for first line treatment. But in general, if you see the first line therapy that were recommended by the guideline in 2019, we see more tyrosine kinase inhibitors as a first line recommendation for treatment besides immunotherapy. So what do we see in the guideline of 2020? As you see in the right figure, there is a major changes. And I conclude this as a shifting paradigm of the systemic treatment for metastatic RCC. If you compare the first line, or it is now mentioned as a standard of care in the guideline of 2020, you will see that the IMDC favorable risk is recommended to be treated by a combination of immunotherapy, pembrolizumab, in combination with tyrosine kinase inhibitor. And also for the intermediate and poor risk, it is recommended to either choose a combination between immunotherapy and TKI or immunotherapy. So this is in general, I may conclude that the standard of care of metastatic RCC treatment in 2020 is more focusing on immunotherapy than targeted therapy. This is a major changes compared to the EAU plan in 2019. But also in the guideline of 2020, it is mentioned that if the patient is not able to tolerate immunotherapies, then targeted therapies can be used. This is just similar to the one of guideline 2019. So again, the standard of care in 2020 is dominantly recommended for immunotherapy rather than targeted therapy. This is important that all of us realize. So the complete guideline mentioned that. What about the recommendation in 2020 if the tumor recurs? So if you see the left figure, it's just the same like the previous slide. This is the standard of care. But should the tumor recur, then it depends. The further treatments as a standard of care depends on what were the previous treatment. If the previous treatment in an IMDC favorable patient received immunotherapy, then if the tumor recur, anti-VEGF or targeted therapy may be offered. This is similar to the one in intermediate and risk. If patients initially receive tyrosine kinase inhibitor or targeted therapy, then for recurrence, immunotherapy is recommended. So this is a major change in the plan of 2020. So I just want to summarize in this slide, what are the options of systemic treatment for metastatic renal cell carcinoma. Basically, we only have 3 categories. The first category is immunotherapy, and this can be offered interferon, either monotherapy or in combination with anti-VEGF, such as bevacizumab. Or the other one is what we call immune checkpoint blockades or checkpoint inhibitors. I believe some of you have are already familiar with this terminology, because in the bladder cancer management and prostate cancer management, the checkpoint inhibitors become a potential options nowadays. So the category of immunotherapies, we have pembrolizumab, we have avelumab, we have atezolizumab, nivolumab, and so on. And then we have what we call the targeted therapies. This may include sunitinib, pazopanib, sorafenib, and so on. And the third is the mTOR inhibitors, consisted of temsirolimus and everolimus. My focus talk today, as I was asked, will focus more on combination of these treatments. I will show you in my next slides the current evidence of combination treatments. Once again, I will not go deeper further into each of the clinical trials as a monotherapy of these drugs, but I'm going to focus more on the clinical trials of combination therapies. So before we continue, I would like to remind all of us and explain a little bit about the mechanism of action for anti-VEGF, such as bevacizumab, and then tyrosine kinase inhibitor or target therapy, and mTOR inhibitors. So basically, as you see in this slide, there are 2 possible ways of working. On the left figure, there are some drugs that are working on the endothelial cells of blood vessels. Anti-VEGF bevacizumab works by inhibiting the VEGF receptor 2. So therefore, the endothelial cell proliferation or survival and migration will not work. And if you see here, the targeted therapies such as sorafenib, sunitinib are also working at the level of endothelial cell. Also, some of the mTOR inhibitors. On the right side, you will see that these drugs not only work on the endothelial cells of blood vessels, but also in the tumor itself. So we have sorafenib, sunitinib as targeted therapies who are interfering with the PI3K pathways. Also, the mTOR inhibitors are also interfering the cascade for tumor proliferation. So basically, if you see this mechanism of action, All the anti-VEGF, TKI, and mTOR inhibitors are either working at the endothelial cells point or inside the tumor itself. There are no place in this slide that describe the way of immunotherapy may give a potential benefit. I would like to continue further. In this slide, I would like to focus on how the immunotherapies, or what we call the immune checkpoint blockade, are working. Basically, tumors can be divided into two categories. One is the one that we call cold tumors, and the other one is hot tumors. So cold and hot tumors actually represent how the T cell activity in a tumor is available. The T cell activity, the T cell infiltration, these are basically the parameter that may categorize tumor into cold or hot tumors. Now, prostate cancer actually is one example of cold tumors, where research have found that the T cell activity and infiltration in prostate cancer cells is very low. Kidney cancer, a little bit dubious or controversial. Some researchers concluded that kidney cancer is categorized as cold tumors, but others has concluded kidney cancer as hot tumors. Basically, the immunotherapies may help at this point and can change or convert the cold tumors into hot tumors by manipulating the immune system. So this is the basic principles of immunotherapies or immunocheckpoint blockade in the treatment of metastatic renal cancer carcinoma. Some of you probably are familiar with the T lymphocyte proteins 4 and then the programmed or death ligand 1. These are all the checkpoints that some immunotherapy drugs are manipulating in order to activate the T cell infiltration and activity, and this may kill the tumor or the cancer cells. So therefore, this is the basic principle where immunotherapies may help cancer treatment. Next is the rationale of combination therapy. So why at the beginning, let's just go back 1 year ago where the guideline of 2019 dominantly recommend tyrosine kinase or targeted therapy as treatment. Why in 1 year it suddenly changes into dominantly immunotherapy as standard of care? This is basically because all tumors, I believe, because a similar phenomenon happened in prostate cancer as or have already described by Professor Hori. The ARV7 in the circulating tumor cells is a marker that may differentiate the successful treatment of prostate cancer with enzalutamide or abiraterone. So people with ARV7 positive in their CTC are at a higher risk of castrate resistant or resistant to the treatment enzalutamide and abiraterone. It's similar to kidney cancer, where basically kidney cancer at the beginning may be treated by anti-VEGF treatment. But in a late stage, there is a different phenomenon going on inside the tumor cells, where this is called the angiogenic phase. Basically, the tyrosine kinase or anti-VEGF treatment will no longer give benefit to reduce the proliferation of cells. This is due to the pro-angiogenic factors that is increasing despite of VEGF targeted therapies. Why does this happen? There are two possibilities of resistancy of anti-tumor treatment. First is what we call primary or intrinsic resistance. This is just an immediate inefficacy attributed to the presence of resistant tumor clones, and this condition is inherited. So therefore, similar to prostate cancer, if someone is inherited with resistant, these people will most likely be resistant with anti-VEGF or tyrosine kinase inhibitors for kidney cancer treatment. The second is the one that we call acquired resistance, and this is due to the changing of characteristic of the tumor itself. And in a simple way, I can describe that the tumor becomes smarter. It is very similar to one cancer. Once you give cancer anti-VEGF, it will work, but only for a certain time. And then in the future, there will be a resistance. And this is the time that we need to figure for second line treatment. So this is all the rationale why combination therapy is necessary in this case. Next is I want to show all of you the four very important combination trials. The first one is called the Keynote 426 study. It is a study comparing sunitinib, this is a targeted therapy or TKI, in comparison with the combination of pembrolizumab and axitinib. Pembrolizumab is an immune checkpoint blockade, and axitinib is a targeted therapy or TKI. So basically, the conclusion shows the combination group shows a longer, about 4 months progression-free survival compared to the sunitinib monotherapy group. And then after a median follow-up of about 1 year, the estimated percentage of patients who are alive at 12 months was higher in the group of combination compared to sunitinib alone. So this is the clinical trial that finally changed our kidney cancer management guideline. The combination between pembrolizumab and axitinib as standard of care for low-risk IMDC category. Next is the Javelin 101. It's a combination between avelumab and axitinib. Again, this is a checkpoint blockade with tyrosine kinase inhibitor compared with sunitinib alone. So the conclusion of this study emphasized that among those with PD-L1 positive expressions, the median progression of free survival was superior in the combination group with 13.8 months compared to sunitinib monotherapy with only 7.2 months. So we have here a 6.6 month significant difference in the combination group between sunitinib alone. And while in the overall population, the first conclusion stated that among the PD-L1 expression positive tumors, the second conclusion mentioned in the overall population, they still showed a superior benefit of progression-free survival in the group of combination compared to sunitinib as monotherapy. The third is the Emotion 151 study. This is a clinical trial phase 3, which combined atezolizumab with bevacizumab. Both are anti-VEGF in combination and compared to sunitinib alone as monotherapy. Again, this combination also resulted among all the PD-L1 positive expression population. The median survival is superior in the group of combination compared to sunitinib alone, with more or less 4.5 months difference of progression-free survival. And next is the Checkmate 2 also comparison. And again, superior benefit in terms of progression-free survival of about 3.2 months in the group of combination compared to sunitinib alone as monotherapy. So those are actually the phase 3 clinical trials, which majorly serve as the landscape for guideline changes in the last 1 year. So now probably some of you would ever ask, so targeted therapies such as, let's just say sunitinib, of course will have some adverse event. I believe some of you have known what are the side effects of tyrosine kinase inhibitors drugs. But if we combine with immunotherapy, in this case, checkpoint blockage immunotherapies, which also have some adverse event, how would be the adverse event in combination? This is something that we need to figure out before we start to prescribe the 2 combination drugs for MRCC. So this slide is summarize one publication in 2019, and basically shows you the effect of, just a minute, this is, okay. The most common side effects. I only summarize the most common side effects of checkpoint inhibitors so that all of you may have a description. What are the risk of consuming checkpoint inhibitors? Majority of the patient will have diarrhea. Some of them will experience pneumonitis, inflammation of the lung, and problems with some hormone levels, also some kidney infections. Next is okay. What about the lasting of checkpoint inhibitor? If we see this figure, it seems that all those patients who consume checkpoint inhibitor drugs will start to have their adverse event after 3 weeks, and some of them even later at 6 or 7 weeks, and will decline. The adverse event will decline after 10 weeks. Some of the adverse event will even stay longer until I don't know how many weeks. This figure shows liver toxicity may occur starting from the 7 weeks until more than 14 weeks. So this kind of adverse event we have to realize before we recommend these combination drugs to our patient. On the other hand, those tyrosine kinase inhibitors or targeted therapies have also side effects. The majority of patients will experience hypertension. The incidence of hypertension is about 20 to 30%. Some of them will experience dysfunction of the left ventricle of the heart, and some of them between 1.3 and 9% will experience bleeding. And if you see the toxicities of fatal events, some of them also very low incidence, 1.5 to 2.5, will have a fatal adverse event when anti-VEGF is combined with tyrosine kinase inhibitor. So now let's see one by one the adverse event of all those 4 important drugs, which has given combination drugs for metastatic RCC patients. The Javelin 101, the one who combined avelumab and axitinib. This is a TKI and checkpoint blockage. If we see here, those with more than grade 3 adverse event has an incidence of diarrhea with 6.7%. And if we see the sunitinib alone group, only shows 2.7%. So this is already 4% differences between the combination group and the monotherapy group. Hypertension, it's similar. The combination group resulted in an incidence of 25% hypertension, while in the monotherapy of sunitinib group experience only 17%. This is just an example to emphasize why the combination group should be given carefully. And the keynote to 6 is also similar. The combination of checkpoint blockage, pembrolizumab, and tyrosine kinase inhibitor shows a, this is disturbing me, the waiting room. A diarrhea of 9.1%. This is doubled, almost doubled than sunitinib alone, and hypertension of 22% compared to 90% of sunitinib alone. Emotion 151, surprisingly, for grade 3 and grade 4 adverse event only shows 40% of adverse event, while in the sunitinib group is even higher than the combination group. And if we see the combination, this is a combination between checkpoint blockage with anti-VEGF. But if we consider the all grades adverse event, this is also similar. The monotherapy of sunitinib is resulted in a lower incidence of adverse event than the combination group. Last is the checkmate 214. You see here that this is also surprisingly, this is a combination of both a checkpoint blockage compared to a tyrosine kinase inhibitor. It shows that sunitinib alone resulted in higher all-grade events, all-grade adverse event with 63% compared to combination group of only 46%. So it depends what kind of combination are we going to prescribe our patients. But basically, in a simple way of, as a reminder, combination drugs should be carefully prescribed and highly considered their combination adverse event, particularly to those patients with comorbidities. In my last slide, I would like to conclude that the standard of care of advanced RCC has shifted, as you see in the changes of the guideline. And the more the 2022 guideline has given more use of immunotherapy rather than targeted therapies. Current trials, especially the 4 phase 3 trials, have shown the benefit of combination to gain survival benefit in advanced RCC. And third, however, adverse event remain an important issue, particularly if checkpoint blockage will be combined with TKI. As you see in my previous slide, I have mentioned if 2 checkpoint blockage were combined, it did not show higher incidence of adverse event combined to sunitinib monotherapy. But if checkpoint blockage combined with tyrosine kinase inhibitor, then according to the 3 recent trials, in general, adverse event are shown higher in the combination group than sunitinib alone. Therefore, only fit patients should be offered and considering all the comorbidities. Thank you very much, Dr. Penta.
Thank you, Dr. Lukman, for your clear presentation, and we will proceed to the next speaker. But before we proceed to the next speaker, I will remind to the audience that CUA point and A certificate will be delivered to you by email after you fill out the Google form in the end of the session. Okay, proceed to the next speaker. We have Dr. Agus Rizal. He will deliver about the role of prostatectomy in high-risk prostate cancer, locally advanced prostate cancer, and low-volume metastatic prostate cancer. Dr. Agus Rizal, the time is yours.
Now it's clear. You can see the slide and also my voice. Okay. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon. First, thank you for all the committee to bring this nice webinar to fulfill our how to say it, craving or starving for the education, because we cannot meet directly and disappointedly that I cannot go to Malang to join again the Malang city. Second, also thank you for the Professor Horie and Professor Isatani that you help us, especially for Indonesian urologists to get more knowledge about the uro-oncology. So my topic is the role of prostatectomy in high-risk, locally advanced, and low-volume metastatic prostate cancer. Actually, there are 3 groups in one title, because the prostate cancer, we call it the localized, and then the localized can categorize become a low risk or intermediate risk and high risk. And then there is another group, we call it locally advanced prostate cancer, and there is a metastatic now can be divided, become to low volume and high volume prostate cancer. As we know that actually the prostatectomy, especially radical, the goal is try to eradicate the cancer, and we try to preserve the continence and potency. The most advantage of this technique, or we do any kind of surgery in cancer disease, that we can take all the cancer cells out of the body. So we don't give a chance of the cancer cell to adapt it, to become resistant to any kind of intervention. But we must realize as a surgeon, there is a prostatectomy is the highest risk of the continence potency complication. We are struggling to overcome this complication that might be become afraid of a patient. So we try to first start from open and then laparoscopy, and then we have now there is a robotic assisted laparoscopy, and still the similar the data showing that oncologic outcome between open laparoscopy and robotic assisted has same result also with the functional outcome, but we're not sure about the long-term follow-up, because as you know that robotic assisted now is become more popular, more data, and then more longer follow-up. We will see in the near future what is more advantage with the robotic assisted. And we already know that actually radical prostatectomy in low risk or intermediates, there is a good advantage or there is no doubt advantage of radical prostatectomy. So now we discuss more about what is for the other group. As you know that the higher risk or the higher stages of the prostate cancer, there is a risk of PSA failure, and also the higher risk of complication and morbidity of the patient. We should think about, is there any secondary therapy, not single or multidisciplinary therapy, and then also higher risk of metastatic progression. And last, as the patient, also the higher risk of death. But what is the problem is I combine the high risk and locally advanced prostate cancer because there is a different definition in guideline. I can show you that actually we only see the locally advanced in AAU guideline. You can see the high risk, the criteria, the PSA more than 20, or not and, but or. So it's been, if there is one criteria of PSA, Gleason score above 7, and C2C, we call, we grouping into the high risk. But if the patient had the CT3 and 4, or with the lymph node positive, we call it locally advanced. So this is the difference. If the lower than T3, then it can be high risk. But if we call a locally advanced, should be T3 and T4. But if you look at the definition in the NCCN guideline, they don't have any definition of locally advanced. And in the high risk, they have a feature of T3A. They difference the difference to the AAU guideline. So, and also they only have the very high with T3B and T4. As remember that before with the AAU guideline, T3A above T3A actually is locally advanced. So it's quite different the definition, stratification in EAHU and the NCCN guideline. So what is the meaning of this different? That can lead to the different sample included in study. And then it's mean a high variety in data, then can be a bias of evidence-based and how we can perform or we select the treatment for this kind of group of prostate cancer. So that's also the question for the clinical question, because there is always debate between radiotherapy with ADT and a radical prostatectomy. Which one goes first in which group? This makes me more. This makes more confusing. There are many data already showing, but there is also contradictory, and that's why we need the systematic review and meta-analysis. But again, as you can see, the inclusion criteria is using the NCCN guideline. So which means we can have a difficulty to separate between high-risk prostate cancer and locally advanced prostate cancer. Of course, they exclude the other criteria. And if we combine all the data, I mean, almost all the data, showing that radical prostatectomy have more survival benefit compared to the radiotherapy in the cancer-specific survival or overall survival. But in some subgroup, there is a different data showing like here that radical prostatectomy had worse outcome of biochemical recurrence-free and worse of metastatic-free and worse of clinical recurrence-free compared to radiotherapy. And also here there is a bias because they try to categorize the study into low T states, but as you can see here, the low T state is if the study included more than 60% of T2 states. With the higher, the other part is, so this is the combine between high risk and then locally advanced. So as you can see here, the radical prostatectomy only give a benefit in low T states, but we're not sure it is high risk or locally advanced disease. This is also when this group do the subgroup analysis with the high Gleason score 9 to 7, it's apparently that radiotherapy had more benefit to improve the cancer-specific survival, or might be also associated with the overall survival. But again, it become more lower because not all the data is coming. This is the subgroup analysis. And then this is the last systematic review, multidisciplinary systematic review. But again, they have a difficulty to separate between high-risk localized prostate cancer and locally advanced prostate cancer, because I think that the definition is different between the European and then the United States and then the data, and we still have confusing which one is better between radiotherapy and radiotherapy. And the other thing, actually, all the study try to compare with the radical prostatectomy with EBRT. There are no randomized, no full text of RCT, and only one prospective observational study. They claim that all the data is the data quality in all this report is low because cannot reflect the final recommendation. However, this data now showing that actually there are consensus that radical prostatectomy should be part of multimodal treatment. So not become the single treatment, but become a multimodal treatment for the high risk and locally advanced. So they give suggestion for both group. And they also claim that the radical prostatectomy actually give at least 10% benefit until 30% for overall survival in 10 years, and cancer-specific around 5% in 10 years. So actually what we need is in the future, we hope there is some group try to do the randomized control trial in specific group, and then we can really answer specifically for high risk or locally advanced. There is one study, there is still recruiting of the patient. We hope maybe in the next 5 years, if you start in 2017, so at least 5, maybe 2022, we can see really the effect of the patient in specific locally advanced prostate cancer. So what the guidelines said now with this kind regard of data, the guidelines, actually in 2019, radical prostatectomy is already suggested in high-risk localized, but with the life expectancy of 10 years only. But in 2020, they skip or they delete the life expectancy. So they offering the radical prostatectomy in high-risk localized prostate cancer as part of potential multimodal therapy. And do not forget, we have to do the extended pelvic lymph node dissection in high-risk prostate cancer, and do not perform frozen section nodes during radical prostatectomy. In this case, to proceed, abandon the procedure. And similar, again, we see the similar recommendation for the locally advanced, actually the radical prostatectomy in highly selected patient with CT3B and T4 and 0 and any lymph node positive as part of multimodal therapy. So the question is how we select the patient. First, we have to aware the patient that surgery with this kind of group is not the only modality. We should explain that after this we do the radiotherapy or ADT afterward. The one suggestion, actually, we have to find the selected patient with a low tumor volume, because we know that in locally advanced T3, at least T3, it can spread or extend to the other, but at least the tumor is not fixed to the pelvic wall. It means that we have to make sure that the MRI or any imaging to look at how the extension of the tumor, and no invasion to the urethral sphincter were found. So this is my personal opinion. I must claim that I am a low volume radical prostatectomy surgeon. Of course, we have to realize that this is the 3 modality that we can suggest to the patient, high risk or locally. And then we decided maybe for the high risk, I will suggest as long that not more than T3, because if you do surgery for T3, it's for the experienced surgeon. I don't know in the future, or maybe Professor Fiti or Professor Isotani can have more experience with what more radical prostatectomy, can perform the T3, and then we suggest for radiotherapy for ADT. But one thing that I always explain to the patient that if I do the radiotherapy first, I cannot go back to the prostatectomy. Yes, there is a salvage prostatectomy, but it makes more difficult doing that kind of surgery. So I always explain these 3 options to the patient, and then let the patient choose which one they are going first for the treatment. Now we move to the low volume metastatic prostate cancer. It is quite interesting because after these 2 popular studies, Chartered and Latitude study, they have divided a group from this study, become 2 group, high volume and low volume, because one is call it more than 4, and Latitude using 2 or at least 3 metastases, but I think we are more using Chartered criteria. So the idea is actually why we offering the local cytoreductive in metastatic. Actually, it started from the kidney cancer, because in the past we know that if we do cytoreductive nephrectomy in metastatic kidney cancer, there is a risk of reduction in some patients. There is a reduction of metastatic site and also the symptoms in the metastatic. This is also that come idea, is it possible we can do the local treatment for the prostate cancer? There is a hypothesis, actually, the hypothesis that a primary tumor here is still connected with the metastatic site because there is interaction here, maybe due with the CTC and with the other cytokine. They are sort of like this. In some hypothesis said this is primary tumor is like a command base for the metastatic. So the idea, if we can do the cytoreductive treatment here, maybe we can reduce the CTC, number of DTC, and then also the cytokine that goes out to the metastatic. Then we hope that we can really reduce, and if we combine with the metastatic site, then we can have more benefit for the patient. So that's why the only one group try to do the cytoreductive, but we cannot start directly to the high volume, because with the high volume metastatic prostate cancer, again, there is a high risk of the comorbidity and also mortality. And then they select with the low volume and try to compare with the regular ADT. As you can see here, they are very strict with the criteria, which candidate that we can do the prostatectomy is if we ensure that we can completely resectable prostate cancer using any imaging. With any imaging, and then with of course with low volume. There is no gross or big retroperitoneal lymph node metastatic, no bulky lymph node with more than centimeter. Of course, no visceral metastasis. They are very selected patient. And as you can see, there is no significant difference between for overall survival, but the clinical progression-free survival, there is a difference. But remember, this is only for 23 cases. Around 20 cases, and it seemed like the overall survivals is a little bit better, but cancer specific also a little bit better. For the biochemical recurrence, it's better when we do the cytoreductive prostatectomy, but the conclusion is only mentioned that a radical or cytoreductive prostatectomy is feasible, so not as part of the treatment of volume, low volume metastatic prostate cancer. Until now, there is no guideline including cytoreductive prostatectomy as a modality in low volume. The guideline only offer the radiotherapy, local radiotherapy in low volume. So I think it needs more time to figure it out. It's interesting, or if one surgeon want to try cytoreductive, and then we should do it as a clinical study. So as a take-home messages, we should consider any treatment with the patient characteristic and condition. We should think that prostatectomy is a part of multimodality for the high risk and locally advanced prostate cancer. As we know that the higher risk and the higher stages, of course, it's much more difficult. And then I suggest only for the experienced surgeon or with the high volume surgeon doing this kind of, especially in locally advanced prostate cancer cases. For me, I'm still studying doing the radical prostatectomy. Then in some patient, we found T3 prostate cancer. It's really difficult to do that kind of surgery. So we should consider about this, and last, cytoreductive prostatectomy still in clinical trial setting in low volume metastatic prostate cancer cases. Thank you very much. Hello.
Okay, thank you, Dr. Rizal, for your clear presentation. And for the last speaker today, we have Dr. Taufik Nurbudaya. Will deliver about the update management in prostate cancer from ASEAN perspective. Dr. Taufik, the time is yours.
Okay, thank you. You can see my screen. Hello.
Very clear, very clear.
Thank you for the opportunity. I will present the last topic in this meeting about the update management on prostate cancer ASEAN perspective. Okay, this is my biggest experience last year. I being part of the big urology department in Japan. One of the most hospital that use the robot in Japan to cure most of the oncologic malignancy, including the nephrectomy, personal nephrectomy, and then radical prostatectomy. I've been studied there for 6 months last year. This is the prevalence of prostate cancer in the world, estimated with a 1,200,000 prostate cancer in the 2018, and then the second most cancer in the man, and the 6th leading cause death in the man. And in Asia, surprisingly, in Israel, and there is the decrease tense of incident of prostate cancer, and the increasing in the China, and maybe in the part of the ASEAN, the prostate cancer diagnosis or incident is increasingly yearly. This is the from WHO data that we know in 2018. We know that almost all of the world, the first case of the malignancy is the prostate cancer, except the several countries in the North Africa, North ASEAN, and then Indonesia itself. The first male cancer is lung cancer. But we see that the mortality is not too high in almost of the world. So the lung cancer is more causing death than the prostate cancer in all of the world. This is the natural history disease of the prostate cancer. We know that the first one, the best treatment is local treatment, local therapy, including the radiotherapy and the prostatectomy. And then we next step is endocrine deprivation therapy, or ADT, whether you can do the orchiectomy or some hormonal treatment. And then if the patient had failed after the local treatment or the ADT, there is the chemotherapy or a second or third line of anti-androgen. So as we know that in Indonesia, especially in Asia and especially in Indonesia, we don't have any large number of localized prostate cancer. And almost all of the prostate cancer diagnosed with the TURP in Indonesia, not by biopsy, because the facility of the biopsy itself, maybe the transrectal biopsy or MRI fusion biopsy, is not available in Indonesia. Just in the big city like Surabaya, Malang, Bandung, Jogja, and maybe Jakarta or Medan, another city, just that diagnose the prostate cancer based on TURP. And then the diagnosis itself for prostate cancer is not completely. It's like we do somehow we do bone scan or PT scan for the screening of the node metastatic or the bone metastatic, but nowadays we just have the bone survey, which is this is not too sensitive for the staging of prostate cancer. So this is, I will compare the guideline, which is NCCN, EU, and of course, Indonesia guideline. And then somehow NCCN have a prostate cancer guideline for Asian perspective. The first one is, this is the global NCCN guideline for the prostate cancer. We know, said that Dr. Rizal said before that for the localized prostate cancer, we divided very low risk group, low risk, and intermediate risk, high risk, and very high risk. But then EU, for the localized, we just low risk, intermediate risk, high risk, and locally advanced and metastatic. So in the very low risk group, if you have life expectancy more than 20 years old, the very low risk group, the initial treatment must be active surveillance, and the second choice is EBRT or brachytherapy, and then the third choice is radical prostatectomy, and the adjuvant treatment may be EBRT and ADT. So in here, IDT is not a primary treatment for the very low risk group for prostate cancer. And if you have life expectancy 10 until 20 years, this recommend that active surveillance is the best. And if you have the patient less than 10 years for less life expectancy, the best choice is just observation the patient. Yeah, this is same for global guideline. So low risk, if you have the patient, the life expectation is less or more than 10 years. So the initial treatment is active surveillance, and then followed by radiotherapy, and the third one is radical prostatectomy. And the adjuvant treatment is after radical prostatectomy, if you have a biochemical recurrence or something like that, you can adding the ABRT and or ADT. So in here still ADT is not the first choice of the low risk group of the prostate cancer. And then if you have a patient with life expectancy less than 10 years, so the best way is just observe the patient. So we shifting to the NCCN guideline in the Asian perspective. Actually, this is almost the same with the global NCCN. You see that the difference is this one. So in the global guideline, there is no place for ADT as the, primary treatment for patient with the prostate cancer in the very low and low. So in the very low, this is same. If you have, you must see the life expectancy of the patient, and then you must decide it. But in the low, there is a place for ADT after as the adjuvant treatment for the prostate cancer. This is why this is the note for the NCCN guideline in the Asia. For low risk patient with life expectancy in less than 10 years, the active surveillance may be the preferred option. But if the patient unable to commit, primary IDT may be a possible treatment option in the selected patient. And for low risk patient with life expectancy less than 10 years, maybe the first choice actually is a radical prostatectomy, and then the second choice is radiotherapy, and the fourth choice is ADT alone. This the statement in base of research of Japanese doctor. You see that? Yeah. So primary IDT has been used for Japan for 80% of low risk patient with 8 years. Cancer specific survival rate is high, about 97%. For low risk patient, it's about 95.5%. So I remember that almost our patient in our center come to us with prostate cancer and then ADT. Patient had been orchiectomy in the peripheral hospital. Some seniors, some of my teacher in rural area said that the most easy management for the urology malignancy is the prostate cancer, because if you know the prostate cancer, if there is prostate cancer, also just orchiectomy and then it is over. So this may be the legacy to do ADT and for low risk and in the locally prostate cancer. If there is an intermediate risk, in the global guideline, we just need the life expectancy less than 10 years. We do this active surveillance, EBRT or radical prostatectomy, and then if you have less than 10 years, you should do the radiotherapy or observation. So this is the same, I think, for the intermediate risk. If your patient lasts more than 10 years for life expectancy, the first one is radical prostatectomy, and the second one is radiotherapy. And then if you have life expectancy patient less than 10 years, the first one is radiotherapy, and then the second one is observation. This is the Asia perspective for the intermediate risk of prostate cancer. Almost the same with the global NCCN guideline for prostate cancer. There is no different. If you have the less than 10 years, the choice is active surveillance and radiotherapy. And you have more than 10 years, you have the choice between radical prostatectomy or radiotherapy. This is the note statement for the NCCN guideline for Asian perspective that for the intermediate risk with life expectancy less than 10 years, primary ADT may be considered as the possible treatment option. The first one is radiotherapy, and the second one is ADT. And if you are a patient intermediate localized prostate cancer with life expectancy more than 10 years, if the first one, of course, the radical prostatectomy. If the patient unable to commit to radical prostatectomy or radiotherapy, or there is no facility for radiotherapy or radical prostatectomy, you can use the primary ADT as the primary treatment for this kind of condition. So why we do the ADT as the first treatment for the prostate cancer, localized prostate cancer? So from the retrospective study, this is I said that before that many intermediate, low risk, intermediate risk have the primary ADT, the life expectancy is so high. And then in Asia, Asian people, that the side effect of ADT is less than the Western people. I don't know why. And the best way is use the combined androgen blockage than the anti-androgen law. Yeah, for the very high risk group, if you have more than 5 years life expectant with symptomatic, the initial treatment is radiotherapy with ADT and plus minus docetaxel, or radiotherapy with ADT, or very strictly radical prostatectomy, as Dr. Rizal said before. If you have patient less than 5 years for life expectant, the best way is observation or a DT alone or a radiotherapy. Just for Asian, I think there is not so different with the global. With the high risk, use radiotherapy, and the radical prostatectomy, the last choice for the high risk. For the locally advanced, the first choice is radiotherapy, and then the ADT. Metastatic is ADT is the first choice for this patient. So if we see the EAU guideline and the prostate cancer, I think this 2019, almost the same. For the low risk, there is no place for ADT for this treatment for this patient. And at the intermediate risk, we just said if the best way is a radical prostatectomy, but if there is no facility for radical prostatectomy or the patient unfit for radical prostatectomy, you can use the radiotherapy with ADT, combination with ADT. And this is do not offer ADT monotherapy to intermediate risk asymptomatic men not able to receive any local treatment. So there is no place for ADT in the localized prostate cancer based on AAU guideline. It is high risk and locally advanced still. For locally advanced, there is a place for ADT, and for high risk locally advanced, the term of primary ADT is not too right. So the AAU guideline said that the first radical prostatectomy in the selected patient with extended lymph node dissection, and if there's patient not fit for radical prostatectomy, the best way is EBRT combined with ADT. For the metastatic, of course, the ADT is still the best choice for this kind of patient. ADT sometimes it's combined with chemotherapy for docetaxel for the newly metastatic prostate cancer. How about in Indonesia? In Indonesia, the last guideline for by Minister of Health is 2017. They know that until the intermediate risk of the locally prostate cancer, there is no place for ADT. And for the high risk and very high risk prostate cancer, there is should be hormonal treatment for this kind of patient. Maybe the Indonesian perspective, it's like EAU guideline for the prostate cancer. I don't know why, because we have actually we have NCCN, we have ASEAN perspective. Why the Indonesian perspective is choice to make EAU guideline prostate cancer. Maybe the lack of data in Indonesia itself. Yeah, for the metastatic disease, the ADT is the gold standard treatment. So this is the original article published in International Journal of Urology in 2006. This UENO, that is based off this paper, said that NCCN ASEAN perspective said that there is a place ADT for the primary treatment of the localized prostate cancer. This is the data. You know that the straight line is for CAB, and this is specific for 5 years is 92.7, and 80 years is 89.1. That is so high survival rate in the primary ADT for the localized prostate cancer. But the best way is CAB compare with monotherapy prostate cancer. If we compare to the non-steroid and steroid anti-androgen, the best way is non-steroid anti-androgen for the primary ADT in the localized prostate cancer. It's the same. It's the Japanese paper that published in Japanese Journal of Clinical Oncology in 2018 say that in Asia, hormone therapy is the treatment option for all stages of patient because the age of at the diagnosis of the prostate cancer is high, and the outcome of hormone therapy is relatively favorable. Whereas for similar stage patient in Western countries treated by surgery and radiation treatment. And the statement of 12 of the NCCN said that ADT for prostate cancer in patient in Asia countries is summarized and differs in both the efficacy and safety profile from use that in Western country. So I mentioned that efficacy of ADT in Asian country, rise of adverse effect such as cardiovascular event is lower than Western population. So the ADT is a choice for the localized prostate cancer in Asian perspective. So maybe in the some rural area, if you don't have a facility for radical prostatectomy or for the radiotherapy, you can simply use the ADT for the treatment of the all prostate cancer. But we saw that there is lack of data regarding cardiovascular impact of ADT in Asian population. Current data on the relationship between ADT and cardiovascular risk are controversial. And then there is lack of data relationship between ADT and diabetes mellitus in the Asian population. So this is different, why the Asian population is different with Western population. This is my paper during my fellowship in Jutendo. There is Professor Horia as my consultant. There's predictive factor to CRPC after the primary ADT, single center in Indonesia, in Malang. So until 2013 and 2018, we have 205 patients with CRPC or mCRPC. And then we record the age, initial PSA level, Bison score, stage of prostate cancer, type of ADT, nadir PSA, time between ADT and nadir PSA, testosterone level after ADT, to see the independent factor that influence the occurrence of CRPC after the ADT. The data said that stage of the prostate cancer, locally and metastatic, is correlated with shortage of the CRPC less than 24 months after the ADT. So if the patient come in the early stage of the prostate cancer and we do the ADT for that time, maybe the time is to get the CRPC is more longer than 24 months. Okay, the conclusion is a difference between Asian perspective and CCN guideline, comparing AAU guideline, global NCCN for prostate cancer in the use of ADT in all stages of the patient. So in the Asian population, ADT had a place for the treatment of the prostate cancer, even in the early prostate cancer.
Oh, sosok bobo kayak ada kerjaan aja sehari.
The operating theater crew, when I studied in Jutendo, see that Professor Isotani used these 3D models, always use the 3D model for the partial nephrectomy robotic. And this photo taken with Professor Craig Rogers from Detroit, USA, when he comes to Jutendo and sharing with us how to do the partial nephrectomy. So this is all of my presentation. Thank you, and Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Dr. Taufik, for your presentation. And now it's time for discussion. There are several questions from the audience. Maybe before to discuss about the question, I will ask to the Prof. Hori first. About the CTC, I'm interested about the CTC. Is there any standard to determine the cutoff point for CTC for Prof. Hori?
Thank you very much for asking this, and it's a very good question. The answer is no, there's no cutoff point. Previously, the relatively older type of machine, you can set some cut point for the number of cells. But in our method, we actually cannot count the number of cells. So it depends which kind of machine you're using. Is
the machine is like a PCR, like a PCR?
Exactly.
Or?
Right. Yes. So what we are detecting CTC by PCR. So actually it's multiplying. So we can tell the existence of CTC or the extent of expression, but we cannot have a definite number of cells.
Okay. Thank you. Now there are a question from the audience. It's from Dr. Taufik, Dr. Andika, Dr. Natal, is to Professor Suji Isotani. Is there any requirement preparation during the patient undergo CT scan so that you can render it into the 3D software? And is there any possibility for printing the 3D technology for the kidney cancer management? Professor Isotani? Where is it? Masih bergabung nggak?
I think he's still taking coffee.
Okay. Well, maybe skip ya. Maybe Dr. Lukman. Oh, Dr. Lukman?
Yes.
Oh, okay, Dr. Isotani is coming.
Okay, thank you.
I'm sorry, the Wi-Fi connection was suddenly stopped. So, what is the question?
Yeah, from Dr. Taufik, Dr. Andika, and Dr. Natal.
So the software is we called it as a Vincent. That it was made by the Fujifilm company. So I can send you the detail. Please contact me the Facebook or the email. I can also contact the company, the Fujifilm company, to let them know to contact you guys. And also can you use with another tumor like the prostate? Yeah, prostate cancer and bladder cancer, that is a kind of sometimes it is difficult because the renal cancer you can detect
3D printing
very easily. However, the bladder cancer and the prostate cancer, it's kind of difficult to modelize in a 3D manner. So maybe that in the future we can do that. And also the basic imaging must be, we use only in a CT scanning because the MRI, the slide thickness is kind of very wide. So it is difficult to make 3D modeling by the MRI. So, and Andika, it's a preparation doing, for CT scanning, we use a very thin slide CT. It is like a 0.5 millimeter slide thickness. You
so
need
the
to
slice, how many slices?
Very thin slide CT for a 3D reconstruction. And also from Nathaniel, have you any?
Is there any possible for 3D printing technology for the model? Terputus kayaknya. Profesor Tani? Terputus. Dr. Lukman? Koneksinya kayaknya.
Yes, Dr. Manta.
Okay. Dr. Luman, dengar?
Ya, dengar.
Okay. I would like to ask about the is there any strategy for the combination therapy? It's given together from the start, or we give the TKE first, and after maybe the result is not good, the combination therapy start.
That's a very good question, Dr. Penta. So I will also answer based on the trials. Actually, why the guideline in 2020 changed, it's because what was the trial name? I forgot. That compare ipilimumab in combination with axitinib versus sunitinib. So in these two arms trials, the ipilimumab and axitinib as combination were given since the first time. So I don't think any uro-oncologist dares to answer the possibility of dividing ipilimumab and axitinib at not similar time, since the clinical trial showed a good benefit for those combination when those two drugs are combined since the beginning. So the answer is, at this moment, we have to give it since the beginning, Dr. Penta. Thank you.
Because the side effect is maybe increase, yeah, every combination.
Yes, I agree with you. That is why I emphasize in my conclusion slide that only fit patients should be offered the combination drugs. If you see the trials, most of the trials between the 4 trials for combinations requires at least a Karnofsky score between 70 and 80%, and without any immunological disorders. So this is important when we combine targeted therapy and immunotherapy.
Thank you, Dr. Lukman. Back to the Professor Isotani.
Isotani sensei. もう一回なんか質問来てる。はい。OK、喋る。
Yes.
Can you, because the connection is not good,
yeah,
can
yes.
you explain once more about the
last question?
The 3D printing technology.
Yeah, 3D printing is very good. It looks like a very easy to understand, and especially for the patient and also the families of the patient. However, it costs too much. It's like $300 or $400 for one printing, 3D printing material. So sometimes it's too much for both of us and the patient, but it is very good materials. So and yes, so we tried several times, but now we stopped making that because of the cost. Is that okay for your questions?
Okay.
Mm-hmm.
Yeah.
So do you have another questions?
The next.
I think Dr. Penta's connection is having trouble.
Mm-hmm.
Can anyone hear my voice?
Yes.
Yes, I can hear you.
I think.
Sorry, the connection is not good.
Yeah.
The question for mati lagi. Sudah. How about the vaccine for adjuvant therapy in prostate, particularly in prostate cancer? Professor Hori. How about the vaccine, Professor Hori, for adjuvant therapy?
Yes, vaccine is previously approved in the United States for metastatic for CRPC, but the benefit of the vaccine is quite marginal. And in Japan, some private clinic developing vaccines using a tumor specimen to sensitize NK cell or DC cell or T cell and giving them back to the patient. But clinic use it as adjuvant therapy, but I'm not sure it has clear benefit. So no solid research has been done and no paper has been published. So I'm not sure it's good to recommend so far. Thank you.
Okay, thank you, Prof. Hori. I will ask to Dr. Rizal. How's the complication rate after radical prostatectomy in high-risk prostate cancer patient?
I think if your how to say your CT2 the clinical state is still T2, the complication still equal, but the problem is increasing if you get the T3, because it can for sure if T3 that you cannot sometimes you cannot preserve the neurovascular bundle. Of course the potency is become lower, and then if you get very big intravesical tumor or intravesical prostate, you need to do the bladder neck construction and also increasing risk of the incontinence afterwards. That's my answer.
Okay, thank you. From Dr. Octoverial to Dr. Lukman, is there still a place for doing surgery in the advanced stage RCC after the combination therapy? If yes, about what time is the best?
Yeah, this is also a good question. I will try to answer it based on two scenarios. The first scenario is based on the scientific evidence that are mentioned in major guidelines. So in the past, I have to admit, probably 5 or even 10 years ago, we surgeons, urologists, tried our best to take out the cancer in a radical surgery. Even sometimes if, as long as the tumor is still resectable. But until last year, to be honest, I have been doing the same, because many constraints are available in Indonesia regarding the targeted therapies. But if you see the recent guideline, the last 3 years in the major guidelines, the role of cytoreductive nephrectomy has become less important. In 2018, there was one publication based on the Carmina trial, C-A-R-M-E-N-A, Carmina trial. It concludes that it compares sunitinib alone versus sunitinib after radical nephrectomy in metastatic RCC patients. And surprisingly, the results was similar overall survival. So this may raise up the question, so what is cytoreductive nephrectomy benefit in this case. So basically, I just want to emphasize that if we see the recent guidelines, my conclusion is that cytoreductive nephrectomy will have less and less reality that we have in Indonesia, where all the targeted therapies or the immunotherapies are not covered by CC patients. So if we see these conditions, one would raise a question, so what should we do for those patients with metastatic RCCs when they cannot afford to buy all these immunotherapy and targeted therapy? To be honest, we are still doing our best to do the radical surgery as long as it is still resectable. Because for sure, they cannot afford those expensive drugs. So before we can send them home without doing anything, at least we can help them by doing radical surgery if the tumor is still resectable. That's my answer, Dr. Benta.
Thank you, Dr. Rukman. I think for the last question, I think it's from Dr. Octavio for Professor Isotani. In order to evaluate the software, do you discuss it with your radiologist or by yourself?
Yeah, actually, I discussed with a radiologist quite a lot to what kind of the CT protocol is good or not. So, and that we need to discuss these things with a radiologist. I recommend you guys to talk with radiologist very frequently.
Thank you. Because of the time is over, I think we should finish the meeting. Thank you for the participant and thank you for the speaker. Stay safe, healthy, because this pandemic situation is very dangerous for us. Thank you. See you next. The next MCUE meeting will be held on 9th on June 2020 at 30 p.m. local time, with the topic is female urology and transplantation. Please check out for our update. We hope to see you again in another online MCUE meeting. Bye. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Terima kasih.
Thank you for all.
Thank you for all.
Yeah.
Yes, gitu.
Thank you, Mas Pen.
Terima kasih semua.